I think having prognostic scoring systems and biomarkers of disease progression is in its early field, and although we have a set of prognostic models that we use every day, but patients behave in a very heterogeneous way, and we do not have the right tools to predict patients who are presenting at early myelofibrosis but are at risk of having very rapidly progressive disease. So that part of science has not yet matured in a way we can predict which patients require the intervention we need. We also want to spare patients who are going to do well for a long time from any intervention because they might not need it and they might be at risk of toxicity. So we have to tailor our therapy to the patients with the highest risk, and that's an evolving field. In addition to that is recognition. So myelofibrosis is a newer disease, and most of our therapies have only been approved for the last 15 years. So as physicians are learning how to use the approved agents and identify patients who will benefit from them, we also need to identify patients who are presenting early and that we can apply interventions that would be worthwhile to help them and change their course. And the third dimension to this is the tools we have. So we have agents that have been tested and tried in advanced diseases, but we do not yet know the merit of these agents in patients before they're advanced. So we still don't have the right interventions, or at least understanding of which interventions would be best to apply in patients with the lowest risk of disease. The good thing is we actually have clinical trials being designed right now for patients with early myelofibrosis. So my answer will change in a few years. We'll actually give you a more specific answer on what should we do in early myelofibrosis.